Hello everyone, very good evening to all of you and welcome to the class. So today we are going to discuss a rapid revision pathology part 4, which will be a mixture type of question because long time there was no discussion with you people, so I just wanted to have discussion of few questions only, right? So short discussion it will be. So let's start with the prayer that you all should have a great and grand success in every exams of your life. And I want to know that if I am able to, can you see me and hear me? Yeah, thank you so much, Rahul, Sushant. Very good evening and happy Teachers' Day to you, all of you, because you all also like a teacher to me. Thank you so much, Pooja, and good evening to all of you. So let's start with the prayer that you all should have a great and grand success in every exams of your life. And here we go. See, after the lecture will be over, you can see all the lecture link will be at my YouTube channel. That is my YouTube channel, and this is the playlist. So this playlist I will recommend you to go through, where I'm having all the pathology live lecture in the last 2 to 3 months, which will be definitely handy for your upcoming NEET PG exam. Thank you so much to all of you. Thank you so much. Thank you so much. Right, so let's start. This is the question number 1. This is a case where biopsy from a blood vessel is taken from a 30-year-old male with inflamed blood vessel, and images given below. Most likely mechanism for this condition is. So what is most likely mechanism for this condition? Thank you so much, Nikhil. Thank you so much, Gayatri. Thanks to all of you. Thanks to all of you. So tell me, what should be right answer? Biopsy from the blood vessel is taken from a 30-year-old male, inflamed blood vessel, and images given below. Most likely mechanism for this condition will be. Yes, so very good. Okay. So Puneet Behani has given me the first correct answer. Puneet Behani, Pooja, Sangadir. So very good. So that's great. So it's a D, right? So correct answer is D. So this is the correct answer. So please remember, this is the correct answer, right? Immune complex mediated. So what I am showing you in this picture, can you tell me what is the finding you are seeing in this diagram which I am showing you here right now? This one, can you see there is a pink material? So what are these pink material? This pink material is a fibrinoid necrosis. So history, see, blood vessel is showing you this, right? And inflammation of the blood vessel, so it means you have to think about vasculitis, right? So inflammation of the blood vessel means you are thinking about vasculitis, right? And in vasculitis, what kind of necrosis we are going to see? We are going to see fibrinoid necrosis, right? So this is a picture of fibrinoid necrosis, and fibrinoid necrosis is mediated by immune complex mediated damage, right? So all fibrin, remember, fibrin will be pink in color. So that is the important point you have to remember. Fibrin will be pink amorphous material, right? So these are the pink material which is a fibrin, right? So here answer is D. Now one by one we will analyze all the options, right? So first I will talk about fibrinoid necrosis is because of endothelial damage. Remember, endothelium is having procoagulant factors, right? And because of endothelial damage, all these procoagulants will be released and they will activate coagulation pathway, right? So endothelial damage anywhere endothelial damage will start coagulation pathway, and coagulation pathway, if it is started, then what will be formed in the end? Fibrin, right? So coagulation pathway will form the fibrin. Now fibrin along with immune complexes, remember, fibrin along with immune complexes, they are going to give rise to fibrinoid necrosis, right? So that is why it is called as fibrinoid, right? So it will be less than 1 hour. It will be less than 1 hour. Don't worry, Shushan. Right? So this is the fibrinoid because they are having fibrin plus immune complex mediated damage, right? So fibrinoid necrosis will be seen in vasculitis and malignant hypertension, right? What will happen in the blood vessel? You can see, as I am showing you in this picture, endothelium is there. Endothelium is getting damaged, and after damage there is a pink material is coming outside. Can you notice these are all pink material which is fibrin? So all this pink material is fibrin, right? And this pink amorphous homogeneous is the description for the fibrin. Now it is the fibrin we are seeing in this blood vessel, right? We are seeing RBC inside the lumen. So this is the blood vessel, and this is the blood vessel wall, and these are the areas where we can see pink material, which is acellular and randomly amorphous material. So these are the fibrin, right? So that is the fibrinoid necrosis. Now look at the necrosis, because there were two options, coagulative necrosis and liquefactive necrosis. So remember, there are two patterns of the necrosis, right? In crescent formation, there will be a fibrinoid. Yes, it can have association, because in malignant hypertension you can see rapid proliferative glomerulonephritis, and fibrin we can see, right? So necrosis, there are two things we have to remember. Either it is due to denaturation of the protein, right? Either it is due to denaturation of the protein, or it can be because of enzymatic digestion. So whenever you are seeing denaturation of the protein is the primary pattern, so tissue architecture, that is very, very important. Tissue architecture will be preserved in case of the denaturation of the protein, because protein is getting denatured, right? For example, if sun is falling on my skin, I am having some denaturation of the protein, but what will happen? I will not be having loss of tissue architecture. So tissue architecture is preserved, so that kind of necrosis is called as coagulative necrosis. Whereas in enzymatic digestion, where enzymes will be causing hydrolytic damage, tissue architecture will be lost, right? And when tissue architecture is lost, that is because of liquefaction done by the hydrolytic enzymes. So this will be called as liquefactive necrosis, right? So now you can see these are the two images, histopath images. Now you can see these are both renal. This is the renal tubular necrosis. This is the renal tubular necrosis, and this is the another renal necrosis. You can see it is not tubular necrosis. This is the liquefactive necrosis. So why we are calling this coagulative necrosis? Can you see all the tubular architecture is intact? Tubular architecture is intact. Only thing which we are not able to see is the nuclei is not visible, right? Nuclei is not visible. So same thing, same mechanism. What I have, Devesh, whatever I have explained the mechanism for fibrinoid necrosis, same will be there for the malignant hypertension also. Blood vessel will be having faster blood flow, endothelial damage, procoagulant release, fibrin release, and then there will be a fibrinoid necrosis, right? So here you can see all the architecture is intact. So this will be a coagulative necrosis, right? So necrotic cells will be having more eosinophilia, and there will be no nuclei. They have lost their nuclei. So that is very important. Whereas in liquefactive necrosis, you can see this is the area of the liquefactive necrosis, where you can see tissue architecture is lost. Actually, glomeruli is seen here, right? Glomeruli is seen here, but in necrotic area you are neither seeing any glomeruli or tubule. So that is what we call tissue architecture is completely lost. So that is the liquefactive necrosis. Now the third one is the fat necrosis. Fat necrosis, on gross examination you are going to see chalky white appearance. Please remember, because here you are going to see the fat will combine with calcium, the free fatty acid will combine with the calcium, and this combination is going to give rise to chalky white appearance, right? So chalky white appearance will be because of fat and the calcium, right? Is it clear? And on microscopic examination, fat necrosis, normal fat cell you have to identify. Normal fat cells will be having eccentric nuclei, and fat filled vacuole is going to push them at the periphery. You can see this is the fat filled vacuole which is pushing the nuclei to the periphery, right? So you can notice that they are pushing the nuclei to the periphery. So that is the normal fat cell. And what happens in necrosis? This nuclei will be degenerated, or you will be damaged. So now you can see nuclei will be damaged. So because of the nuclei damage in necrotic fat cell, you will not see any nuclei. So there is no nucleus, right? Or you can also call them as a anucleated ghost cells, right? And because of the chalky white is because of the calcium deposition, right? So they may have a amorphous basophilic deposit into the cytoplasm. And remember, this amorphous basophilic deposit is calcium only, right? So that is the calcium only which is having amorphous. So now I will show you the picture. This is the chalky white appearance which came in the NEET PG exam. Can you see this? This is the chalky white appearance. These are all fat necrosis, right? So all these things are the area which are showing you fat necrosis, chalky white appearance, right? Yeah, liquefactive necrosis can be seen anywhere where you are going to see infection. Enzymes will be released, and they will again cause the liquefactive necrosis. right? So it can be seen at any place. Wherever you are going to see the infection, bacterial toxins, enzymes will be released and they will be causing lipofactive necrosis. It's a general topic, it's a miscellaneous topic, it's a miscellaneous topic. So now you understood. So this is the fat necrosis, which we will be seeing chalky white necrosis, right? Now on the microscopic examination, you can see these are the normal fat cell. Can you notice this is the normal fat cell which I am showing you here? In this you can notice the nuclei and you can see the fat filled vacuole is pushing them to the periphery, right? So what I am showing you here is the normal fat cell, right? Now you see at this fat necrosis, all the fat cells are having hemorrhagic or some fluid material and none of them is having nuclei. Can you see there is no nuclei in any of them? So all these are anucleated ghost cells. So all these are anucleated ghost cells and this is the fat necrosis, right? So done. Come to the next question. Which of the following will be activating MLKL during programmed cell death? Which of the following will be activating MLKL during programmed cell death? What should be right answer? Calcium is basophilic. Calcium will be amorphous basophilic material. So tell me, what should be right answer for this question? A. Okay. Okay, so Puneet has given me the first correct answer, that is the RIP3. Very good. So Puneet has given me first correct answer. D is the correct answer, RIP3. Divya, Puneet, all have given me the correct answer, right? So it is RIP3, right? Very good. So Pooja, everyone who has given RIP3 right answer, that's very good response, right? So what I'm talking about, MLKL, programmed cell death. So can you tell me which programmed cell death I'm talking about? Pyroptosis, necroptosis, or apoptosis? Can you tell me what I'm talking about in this condition? What is this? So this is example of which programmed cell death? When you find MLKL, right? When you find MLKL, please remember, when you discuss about MLKL, so it means it is going to be activated by RIP3. Actually RIP3 is going to activate the MLKL phosphorylation and this will be seen in necroptosis, right? So this is the finding we are going to see in the necroptosis. So this is the right answer. RIP3 is going to activate. Caspase 1 and 11, they are associated with pyroptosis, right? So there was a question in NEET PG exam 2018, right? Who will activate interleukin 1? Right? Who will activate interleukin 1? So interleukin 1 activation is done by all caspases 1, right? 1, 4, 5 and 11. So these are the caspases which are associated with pyroptosis, right? So these are all pyroptosis associated caspase 1, 4, 5, 11 and all are associated with interleukin 1 activation, right? So that point also you have to keep in mind. Examiner can ask you this question again, right? So now I will just brief you about necroptosis. What is necroptosis? It is a programmed cell death without caspase involvement. So here I would like to tell you one thing. Just I'll go back. I would like to add something, right? So if we talk about programmed cell death, right? If we talk about programmed cell death, right? So programmed cell death, we can divide them into two categories, right? Without caspase and with caspase, right? So when we talk about without caspase, that will be called as necroptosis, right? So that will be called as necroptosis. With caspase, this can be apoptosis also, this can be pyroptosis also, right? So in apoptosis, you are going to see the different caspases like a 3, 6, 7, 8, 9, 10, right? And in pyroptosis, we are going to see caspase 1, 4, 5 and 11. So now you understood. So programmed cell death can be of two types. Without caspase, right? Without caspase, it is necroptosis. with caspase 3, 6, 7, 8, 9 apoptosis, and 1, 4, 5, 11 it is pyroptosis, right? So now in this necroptosis, as we can see, there is no caspase involved, so there will be tumor necrosis factor which is going to combine with receptor like this. So this combination of the tumor necrosis factor and receptor will recruit the receptor interacting protein kinase 1, right? And then they are going to recruit receptor interacting protein kinase 3. So RIPK1 and then recruitment of the RIPK3. And remember, this RIPK3 is going to induce MLKL phosphorylation, right? So RIPK3 will induce MLKL phosphorylation. MLKL will form oligomers which will deposit into the cell membrane. And after into the deposition into the cell membrane, they are going to cause damage of the cell membrane, and that will lead to the inflammation. So that is the process of necroptosis. It starts from the death receptor TNFR, which combines with TNF RIPK1. RIPK3 is recruited. RIPK3 will activate phosphorylation, which will deposit MLKL into the membrane, and this MLKL will be causing cell membrane damage and inflammation, right? So now I understood. So that is the process of necroptosis, where you are going to see cell membrane damage and process of inflammation. So necroptosis resembles like a necrosis, right? And what happens in pyroptosis, as I said, there is a caspase involvement. So in this, whenever antigen comes, and what antigen we are going to see in the pyroptosis, so remember, mostly these antigens are flagellin, right? So these antigens are flagellin. So flagellin antigen can combine with the membranous toll-like receptor also directly on the membrane, or they can go inside the cytoplasm to combine with nod-like receptor also. So now you can see that there are two involvement: toll-like receptor, nod-like receptor, right? When they combine with nod-like receptor, they will activate pro-caspase 11 into caspase 11. So now you can see these are the caspase 11 involvement in the pyroptosis, right? If they reach into the cytoplasm directly, and they will be combining with nod-like receptor, so this will activate the inflammasome. Inflammasome will activate the procaspase 145. So now you can see 145 will be activated to 145, and this 145 is going to activate interleukin 1, right? So now I understood. So that interleukin 1 is the inflammatory cytokine which will be causing cell membrane damage and inflammation. So you might be thinking 145 is okay, but how it is say 11, how it is caspase 11 associated with this one, right? So remember, caspase 11 has a tendency to activate this step. So caspase 11 will also do the activation of 145 to activate the 145, right? So now I understood. So caspase 11 can also do this kind of activation. So that is why caspase 1, 4, 5, 11 all are associated with activation of the interleukin 1. So that will lead to the cell membrane damage and inflammation. So this is the pyroptosis, where you can see caspases are involved, and these caspases are different. So 1, 4, 5 and 11 is associated with pyroptosis, right? So done. Moving on to the next question. A 35-year-old male presented with mild cough, mild fever from past few days. Lab evaluation, his total leukocyte counts were within normal limit. On radiological examination, chest x-ray was showing you finding within normal limit. Lung tissue biopsy is given here, right? So most likely correct statement about this condition is. So this is very potential question in the NEET PG exam, and you can see question again in the upcoming exam. So what should be right answer for this question? Tell me. Very good. So I think Puneet again has given me the first correct answer, that is the D. So what is your diagnosis by seeing this picture? Can you tell me what is your diagnosis? So we are seeing lung biopsy. So this is the alveoli, right? So you can see these are the alveolar septa, and this is the alveoli. Within the alveoli, you can see there is a multinucleated giant cell which is having eosinophilic inclusions into the cytoplasm also and into the nuclei also, right? So it is a viral inclusion within the nucleus and cytoplasm both, right? So this is the correct statement. Star shaped abscess due to neutrophilic infiltration. First of all, you are not seeing any star shaped abscess or neutrophilic infiltration. So star shape, in all these things will be seen in which condition? Star shaped abscess due to neutrophilic inflammation. This will be seen in stellate granuloma, right? This will be seen in stellate granuloma caused by cat scratch disease, right? So that is not in this case. It is not a cat scratch disease because there is no stellate granuloma, there is no star shaped abscess. Fibrin ring granuloma will be seen in which condition? So fibrin ring granuloma you will find in the Q fever, or even in Hodgkin's lymphoma you can see, right? So we are not seeing any fibrin. Are you seeing any fibrin here? So there is no fibrin, there is no ring, right? So it's not a fibrin ring granuloma. Basophilic viral inclusions. Basophilic viral inclusions are seen in cytomegalovirus infection, right? So it is seen in cytomegalo. So here you are not seeing any basophilic. You can see all are looking eosinophilic dot like structure. So there is a eosinophilic viral inclusions are present, right? And these eosinophilic viral inclusions are present in which area? We are seeing in the cytoplasm also, and we are noticing them inside the nuclei also. So what is this? It is a Warthin-Finkeldy giant cell, right? So these are Warthin-Finkeldy giant cell, and Warthin-Finkeldy giant cells are seen in which condition? It will be seen in measles, right? So this is the Het's pneumonia, which is a atypical pneumonia, right? Het's pneumonia or atypical pneumonia. That is why you can see in this patient you are seeing radiological examination. Can you notice on radiological examination he is having normal finding? On lab evaluation, total leukocyte is again within normal limit. So probably this is the atypical pneumonia, which is quite commonly seen in the viral infection, right? So this is the Warthin-Finkeldy giant cell because of the measles infection, and that is why his radiological and all these things are normal limit, because this is a atypical pneumonia where we are seeing no findings in the radiology or in the total leukocyte count, right? So that is the measles and Warthin-Finkeldy giant cell. So what is correct answer? So D is the correct answer. So the fourth one is the correct answer. Viral inclusion are seen. So you can see all these eosinophilic pinpoint, and the similar eosinophilic structures are present inside the nuclei. So within the nucleus also, within the cytoplasm. So this is the correct answer, right? Now I'll just show you some of the important point here. So already we have discussed it. So now come to this one. Can you tell me what is this? This is, can you notice, this is the fibrin ring granuloma. If you look at this, there is a central part which is clear. Why central part is clear? Because of lipid. So you can see this is the central part corresponding to this one, right? So central part is clear because of the presence of lipid. It will not catch up the stain. And then you can see there is a inner ring and there is a outer ring, right? So these are the inner and outer ring. So that is why it is also called as donut granuloma, because it resembles like a donut. Can you see this? There is a picture here which I am showing you, donut, right? So donut granuloma. So this is the fibrin ring granuloma or donut granuloma, because in this ring you can notice these are the area where you can see pink material, which is fibrin, and these are epithelioid cell. Can you see elongated cells are epithelioid cells, and all these round cells are lymphocytic infiltrate. So what is this? This is a fibrin ring granuloma, right? So this is the fibrin ring granuloma. Fibrin ring granuloma is also known as looks like a donut, right? So also known as donut granuloma, right? So also known as donut granuloma, which will be seen in Q fever, right? So now you can see this is because of lipid, there is a clear area, right? And these are the epithelioid cells, right? These are the epithelioid cells, and these are the inflammatory cells, right? Inflammatory cells. And pink material which we are seeing is the fibrin. So that is why it is a ring like fibrin ring like granuloma, which will be seen in the Q fever and Hodgkin's lymphoma, right? Now look at this one. Can you see this? How is the appearance of this area? This looks like a star shape. So we are seeing eosinophilic area. It's a necrotic area, right? It's a necrotic area. And this area is showing you the nuclear dust, right? So this is the necrotic area and there are nuclear dust, and this is all looking like a star shape. So this will be called as stellate granuloma, right? So this is the stellate granuloma. Where we are going to see this? We are going to see this in the cat scratch disease, right? Now come to the next question. Histopathology of Hodgkin's lymphoma patient is given below. Which of the following is correct statement? Which of the following is correct statement? So tell me. Right, so who has given me first correct answers? Which is correct statement? Right, Sunil has given me the first correct answer. It is C. It is C which is correct answer. Yes, yes, very good. So please remember, this is a what kind of question? Can you see this? What is this Hodgkin's lymphoma? Can you notice this Hodgkin's lymphoma cell? There are multi-lobated nuclei. So what is this? What is this? This is the popcorn cell, na? This is the popcorn Reed-Sternberg cell. Where you are going to see popcorn Reed-Sternberg cells? In lymphocyte predominant Hodgkin's lymphoma, right? So this is the lymphocyte predominant Hodgkin's lymphoma. So please remember, this is how you have to identify. Whenever you are going to see a lymphocyte predominant, you are going to see either multi-lobated nuclei or polypoidal nuclear lobe, right? So this is the Reed-Sternberg cell, which is called as popcorn Reed-Sternberg cell, right? So these are the popcorn Reed-Sternberg cells, which you will see in the lymphocyte predominant Hodgkin's lymphoma, right? So these are the lymphocyte predominant Hodgkin's lymphoma. So lymphocyte predominant Hodgkin's lymphoma, what we should remember, they are BCL6 positive. They arise from the germinal center. Please remember, they arise from the germinal center. So that is why BCL6 is a marker of germinal center. So they will not be negative, they will be positive. So this is the incorrect, right? This is the incorrect. CD15 and CD30 positivity will be seen in classical Reed-Sternberg cell. It will be seen in classical Hodgkin's lymphoma. Lymphocyte predominant is non-classical, right? They are non-classical, right? So that is not a classical one, and they will be 15-30 negative. So remember, BCL6 positive, but CD15 negative, CD30 negative. Not associated. Usually we all know that Hodgkin's lymphoma is having a stronger association with the Epstein-Barr virus, but remember, when we talk about lymphocyte predominant, they are not associated with Epstein-Barr virus infection. So that is the another important point you have to remember, right? So this is a true statement, not associated with Epstein-Barr virus. Most commonly associated with HIV infections. Most commonly associated with HIV infection. So remember, HIV infection is most commonly associated with the mixed cellularity, right? So this is not a correct statement. HIV infection is most commonly associated with mixed cellularity type of Hodgkin's lymphoma. Is it clear? So this will be mixed cellularity, not with the lymphocyte predominant. So please remember this point. These lymphocyte predominant Reed-Sternberg cells are BCL6 positive, 15-30 negative. So what will be other CD markers which will be positive in this case? So please remember, they will be positive for CD20 and CD45, right? So this will be positive in the Hodgkin's lymphoma, right? So clear? Fine. So moving on to the next question. A 23-year-old male. So you got the answer. What is the correct answer? Correct answer is C, right? It is not associated with Epstein-Barr virus, right? So please remember, you have to identify the popcorn Reed-Sternberg cell And after identification of the popcorn, how you are going to identify? Multilobated nuclei will be there, or polypoidal nuclei will be there. So that is how you are going to diagnose lymphocyte predominant by seeing the popcorn. And you will remember they are BCL6 positive, 1530 negative, and they are not associated with Epstein-Barr virus infection. That was the question in the PGI and NEET and AIMS all exams, right? And most commonly associated with HIV infection will be the mixed cellularity, right? Fine. So 23-year-old male with chronic liver disease, I can assure you this is one of the ubiquitous topic which I am asking. I have seen this question, in this type of question, this topic in the NEET exam also, FMG also, and AIMS also recently asked. 23-year-old male, chronic liver disease, evaluated and found to be having findings as shown in this image. Condition is most likely to be associated with which of the following alterations? So what should be right answer? Actually, this should be which of the following is the correct about this one. Which of the following here actually multiple answers can be correct. See, if you look at this, if this is the KF ring, right? KF ring, and what is your diagnosis? Wilson's disease, right? So our diagnosis will be Wilson's disease. So here diagnosis is Wilson's disease, right? So which is correct about this condition, right? So can you see rhodamine stain will stain copper green? Will they stain copper green? So please remember, rhodamine stain is used for copper, that is true, but rhodamine stain will be not giving them a green color. This will be giving brown color. So this will be giving red brown color. So this is the correct statement, not the green color. Micronodular cirrhosis will be seen. So please remember here, because of the Wilson disease, you are not going to see micronodular. Here you are going to see macronodular cirrhosis, right? So macronodular cirrhosis will be seen in the Wilson's disease, right? KF ring has no association with neuropsychiatric symptom. That was the question in previous year INICT exam. So that is a false statement, right? They will have a strong association. More than 99.9% will be having a strong association with the neuropsychiatric, right? So that is the wrong statement. KF ring has association with neuropsychiatric symptom. So as an ophthalmologist, whenever you see KF ring in a Wilson disease, you can understand that this patient will have neuropsychiatric symptom, and you should refer that patient to the psychiatry OPD also, right? So D is the correct answer. Degeneration of dopaminergic neuron can be seen, right? So degeneration of the dopaminergic neuron can be seen because of the copper deposition. So remember, in Wilson disease there is a excessive copper deposition, and they can cause damage of the basal ganglia, right? So they can cause damage of the basal ganglia, and that is why this disorder is also known as hepatolenticular degeneration. Hepatolenticular degeneration. So this is the correct answer, right? So D is the correct answer. So I'll just show you some important point about the Wilson disease. Is an autosomal recessive disorder. Chromosome is 13 long arm. So remember, it is 13 long arm, 13q, right? And what it encodes? It encodes for ATP7B. ATP7B gene is encoded by 13q, right? What is the problem in Wilson disease? This gene will be having mutation. So ATP7B, what actually they do? They control ceruloplasmin synthesis, right? They control ceruloplasmin synthesis, and ceruloplasmin, right? Ceruloplasmin will be decreased because of mutation in ATP7B. That was also DPG question. Wilson disease, chromosome 13q, ATP7B gene will be having mutation. Because of that, there is a decreased ceruloplasmin. Ceruloplasmin is a carrier protein for the copper. So if ceruloplasmin level is low, so what will happen? there will be decreased copper combination with the ceruloplasmin, because ceruloplasmin is not there. What is their purpose? To carry them for the biliary excretion. So no ceruloplasmin, no copper combination, and no copper biliary excretion. So as a result, what is happening? Copper is not getting excreted, so it is going to get accumulated into the tissue, right? It is going to get accumulated into the tissue, and this copper accumulation into the tissue will be the reason for development of Wilson disease, where majority of the things will be happening with the liver, right? So majority features will be liver disorder associated and hemolytic anemia. Other organs will be also affected, like eye, brain, all these things. But whenever you find a liver disorder along with hemolytic anemia, you should have a suspicion for Wilson disease, right? So in this, what we are going to see, first of all, we have to remember Wilson disease will be symptomatic by the age of 6 to 20 years. So as I said, liver, brain, and eyes all will be affected in the Wilson disease. So in liver, what we are going to see, acute, chronic, fulminant, all spectrum of hepatitis will be there. Remember, that is very, very important MCQ. All spectrum of hepatitis can be seen in the Wilson disease. They will have macronodular cirrhosis, and there will be a presence of Mallory-Denk bodies, which is consisting of cytokeratin 8 and 18, right? Brain will be having basal ganglia damage. As I said, why it is called as hepatolenticular degeneration, because in basal ganglia, putamen will be having atrophy and cavity, right? So because of the basal ganglia damage, putamen damage, there will be the risk for the Parkinson's disease. So that is why whenever you are seeing a Parkinson disease patient, you will always order to see the ceruloplasmin level, so that you should rule out that prior to this patient was actually having Wilson disease. What I mean to say that Wilson disease can lead to the Parkinson disease in the later age. So that is why we have to rule out the ceruloplasmin deficiency leading to the Wilson disease in case of any Parkinson. So whenever you are evaluating Parkinson, you will always do all these things in your practical life also, right? And eyes, you are going to see sunflower cataract, number 1, and Kaiser-Fleischer ring. You can see in the cornea with the naked eye also, but it is best seen by slit lamp examination. And in cornea also, it is in deposition into the decimate membrane, and it will be giving you a yellow brown color, right? So that is about Wilson disease. When we come to the diagnosis of the Wilson disease, most specific method is the increased urinary copper excretion. Remember, most specific is the urinary copper excretion. And gold standard, see, gold standard means we're not using very commonly, right? But when nothing is visible, then you have to go for the gold standard. So gold standard is liver biopsy, and copper will be more than 200 microgram per gram of the liver tissue. That will be confirmatory. Remember, it is should be more than 200 microgram per gram of the liver tissue, and that is the gold standard. And a special stain, we are going to use rhodamine stain, which will be showing you red brown copper accumulation, right? So here serum ceruloplasmin is decreased. Serum copper level is non-diagnostic because it will be variable. It can be increased, it can be decreased, it can be normal. So this is AIMS question. Serum copper level is non-diagnostic. Ceruloplasmin is diagnostic, but copper level is non-diagnostic in the Wilson disease. And this is the Harrison picture which I wanted to show you, Harrison table. You can notice here Kaiser-Fleischer ring is present, right? And it is present in 99% if neurologic or psychiatric symptoms are present. Right, so that is what I was telling you. KF ring is having a strong association with KF in this neuropsychiatric features, right? And if you look at the urinary copper will be increased in case of the Wilson disease, right? And liver copper, it should be more than 200 microgram per gram per dry weight of the liver tissue, right? So that is the gold standard, right? Nowadays ATP7B gene mutation, right, all haplotype analysis, these are the recent updates which you have to remember, which will confirm, which will be the best investigation right now, but it will be very costly, so that is why it is avoided, right? So now understood. So answer for this question is D, right? Degeneration of dopaminergic neuron because of risk of Parkinson disease. We are going to anticipate these kind of changes in the Wilson's disease, right? Now coming to the next question. This is the last question. A 5-year-old girl was noticed to have a blood-stained underwear and protruding mass from her external genitalia. Clinical examination shows polypoidal grape-like masses projecting from the vagina. Histopathological examination of a biopsy specimen from the lesion is shown below. right? This is the histopathological. So most likely correct statement will be. So what will be the most likely correct statement for this question? Tell me. Very good. So this is sarcoma botrytis, no doubt, right? So tell me what should be the correct answer. So Purkinje, who is Purkinje? Purkinje has given me the first correct answer. Answer should be the D. Strap cells are characteristic finding. See, those who have given tennis racket, probably they have not read this word. Tennis racket appearance seen ultrastructurally. What is this? What is this? Tennis racket cells are seen ultrastructurally means on electron microscopy. It is talking about Birbeck granule. It is talking about Birbeck granule, which you see in Langerhans histiocytosis. It is appearance. Remember, tennis racket cells will be seen here. See, the history which I have given here is a sarcoma botrytis history. Right? This is the history of sarcoma botrytis, which is a embryonal rhabdomyosarcoma of the vagina. Right? So embryonal rhabdomyosarcoma will be positive for desmin. Right? So it is not vimentin positive. So it is not vimentin positive. It will be desmin positive. Beta HCG is the tumor marker for choriocarcinoma, not for here. Right? Tennis racket appearance is seen in Langerhans cell histiocytosis. Strap cell is the characteristic finding. Strap cells are also known as, so this is the right answer. Strap cells are also known as rhabdomyoblasts. Right, so they are also known as rhabdomyoblast, and this will be seen in the embryonal rhabdomyosarcoma. And remember, this will be described as a tennis racket cell because of the cytoplasmic protrusions like this. So they are called as tennis racket cell. This is the nucleus, also known as tennis racket cell, or also known as you can see, strap cells. So tennis racket cell, strap cells are also known as tadpole cells. So now you understood. So this kind of mistake what you have done by choosing answer tennis racket appearance is a lesson that you should read each and every line very carefully during exam, because this is a silly mistake. You know it. I know that those who have given this answer, they know it very well that it is for Birbeck granule, but probably in a hurry they have missed this line. So tennis racket appearance and ultrastructurally means electron microscopically. So this is the Birbeck granule seen in Langerhans cell histiocytosis. Strap cells are the rhabdomyoblast, which are also called as strap cell, tadpole cell, or tennis racket cells. These are cells and seen on the light microscopic examination. So now you can see there are so many tadpole cells are visible here, right? So there are so many tadpole cells are visible here. You can see this is the beautiful tadpole cell. You can see this nucleus is there inside, and cytoplasm is protruding. Cytoplasm is having protrusion like this, and that is why it is called as tadpole cell, right? अरे ऐसा मत सोचो रजनी, डोंट थिंक दैट कि there is nothing called fix. Still you have time, and you can definitely get into exam. See, do not give up at this moment. This is the time where we have to compose yourself, because if you are thinking about next year, so next year again you are going to have same thought process. So don't think like that, because this is a common tendency. It's a common human behavior. In the last moment we think like that, and this is the sign of giving up. So don't give up right now. You stay on, revise 1 year question paper, and things will come to your mind. Don't worry that you do not remember this thing or some silly mistake is happening. So don't worry. So this is the last question. So some flashcard based description I'm going to see. This sarcoma botrytis. What is sarcoma botrytis? As I said, this is a variant of embryonal rhabdomyosarcoma. So it is a skeletal muscle tumor of vagina in children less than 5-year-old. Right? So what is this? It is a variant of embryonal rhabdomyosarcoma. Right? So skeletal muscle tumor, less than 5 year, variant of embryonal rhabdomyosarcoma. Gross finding, now you can see this is the cluster of grape like mass which is protruding from the vagina, right? So this is described as a cluster of grape like tumor mass coming outside from the vagina, right? And because of this cluster of grape only, it is called as botryoids, right? When we are going to see microscopic examination, you can see rhabdomyoblasts are visible, which are tumor cells, which are tennis racket cell or tadpole cell. Already I have shown you in the question, right? So these are the tadpole cell or tennis racket cell. What is very characteristic on the low power scanner view itself, can you see this? There is a epidermis. So this is the epidermis and this is the dermis. And dermoepidermal junction, you can see there are tumor cells. So you can see there are tumor cells. So you can notice there is a hypercellular poorly differentiated tumor cell. So this layer where you can see, can you see this? This is the hypercellular poorly differentiated tumor cell. So this layer is called as cambium layer. That was also NEET PG question. Cambium layer will be seen in sarcoma botryoids or embryonal rhabdomyosarcoma. What is the meaning? Subepidermal area will be showing you hypercellular poorly differentiated tumor cells, right? So epidermis will be nothing, having no tumor cell. Dermis will be having hypercellular poorly differentiated tumor. So that is called cambium layer. So cambium layer will be seen in embryonal rhabdomyosarcoma, right? So these are all important points. So very good night to all of you. Keep studying, keep revising, do not give up. Don't worry about all these things, right? Don't worry about कोई जितना भी पढ़ा होगा, even the topper will be having this kind of nightmare. Right now I'm not able to recall. See, we are all human being, right? We cannot remember each and everything at all the time, right? So please don't think all that thing. You will remember during exam time. Have this kind of positivity. You would have seen in 10th also, 12th also, when we go for our final board exam, we think that we are not going to remember in our university exam, but when we appear in exam, everything will be coming in our mind. So please do not worry about all that thing. Don't get deterred by all these kind of mistakes or silly mistakes. It will happen. We are human being. I am telling you, give yourself a leniency of 1 to 3% of silly mistake. Everybody is going to do 1 to 3% of silly mistake. Everybody is going to do. Only only difference is 3% will be done by the topper, 5% done by those who are in the top 1000 rank, 5 to 8% will be done by those who are from 1000 to 6000 rank. So like that it will be going on. So there will be a silly mistake. Nobody can become perfect. Even if you are going to next year with full preparation, you get rank 1, then also you are going to do all these silly mistakes. So don't worry about that thing, right? So thank you so much to all of you. Do not give up. Keep revising all these notes. You will definitely get a very good ranks, right? So bye bye. Good night.